I need you to stay with me for the next few minutes, not because this is complicated, but because what I am about to tell you may directly affect your safety the next time you get out of bed in the middle of the night. There is a specific time of day when blood pressure medication, the very pill that is supposed to protect you, can quietly become one of the greatest fall risks in your home. And millions of seniors are hitting that moment every single night without ever being warned. My name is Dr. Benita Fieldhouse, and today I am going to give you something more valuable than a prescription review. I am going to give you the conversation your doctor probably has not had time to have with you yet. Because the most dangerous time to take blood pressure medication is not always the time most people assume. In fact, for a significant number of older adults, the timing they have been following for years, believing it is the safest, most responsible choice, may be the very thing increasing their risk of a fall, a fracture, or a terrifying episode of blacking out in the dark. If you take blood pressure medication, if you have ever felt dizzy getting up in the night, if you have ever had to grab a wall or steady yourself before taking your first few steps in the morning, this message is for you. Let me begin with a woman I want you to meet. Her name is Eleanor. Eleanor was 76 years old, sharp, independent, the kind of person who color-coded her weekly pill organizer and never missed a dose. Her daughter admired it. Her doctor appreciated it. Eleanor had her blood pressure tablet on her bedside table and took it every single night at exactly 10 o'clock. No exceptions, no delays. She believed that made her the model patient. Then one night, at just after 2 in the morning, she got up to use the bathroom. 3 steps down the hallway, the room tilted sideways. Her knees gave way. She caught the wall with one hand, but it was not enough. She went down hard. Eleanor survived, but she fractured her wrist. And she told her daughter afterwards that the worst part was not the pain, it was the fear. The complete disorientation of not understanding what had just happened to her body. It was not a stroke. It was not a heart attack. It was not the wrong medication. It was timing. More specifically, it was what happened when medication timing collided with her body's natural overnight blood pressure drop, the act of standing up quickly, the darkness of the hallway, and the particular vulnerabilities that come with an aging circulatory system. None of those things would have caused harm alone. Together, they created the perfect storm. That is why this conversation matters so much, because the danger does not announce itself. You do not feel it when you swallow the pill. You do not feel it when you climb into bed. You feel it hours later, in the dark, when it is already too late to prepare. Now, before I go further, I need to give you one foundational piece of understanding that changes how you see everything else. Blood pressure is not a fixed number. It is not your shoe size. It does not stay constant from morning to night. It rises and falls all day long. When you wake up, when you move, when you eat, when you feel stressed, when you feel calm, when you stand up from sitting, and especially during sleep. In most healthy people, blood pressure naturally dips overnight. That is not a problem. That is normal physiology. The body is designed to do that. But here is where it becomes dangerous. If medication is taken at a time that intensifies that natural overnight dip, blood pressure can fall lower than the brain and body can comfortably tolerate. And when that happens, dizziness follows, fainting follows, falls follow. And in older adults, falls are not simply embarrassing, they can be life-changing. This is where a great deal of confusion has taken hold in recent years. There has been ongoing debate in the medical community about whether blood pressure medication is better taken in the morning or at night. Some research suggested that evening dosing might offer better protection against early morning blood pressure surges. Other evidence pointed in a different direction. People heard fragments of these discussions through television segments, online health forums, conversations with neighbors, and began making decisions based on incomplete information. The truth is far more nuanced than any headline can capture. There is no universal safe clock time for every person. There is no blanket rule that works for every senior taking every type of blood pressure medication. And the assumption that bedtime is automatically the safest or smartest choice can be genuinely dangerous for many older adults. I want to tell you about a man named Frank to show you exactly why. Frank was 72, retired. He had high blood pressure and some mild swelling in his legs. His doctor had prescribed 2 medications, a standard blood pressure tablet and a diuretic, which is a water pill, a medication designed to help the body shed excess salt and fluid through urine. Frank heard from a relative that taking blood pressure medication at night was better for heart health. It sounded sensible to him. So without mentioning it to anyone, he shifted both tablets to 9:30 in the evening. He thought he was being smart. He thought he was giving his heart an extra advantage. Within a week, he was waking up 3, 4, sometimes 5 times a night to urinate. He was exhausted during the day. His mouth was parched every morning. He felt shaky when he stood up. One night, still half asleep and rushing to the bathroom, he nearly caught his foot on a rug at the edge of the bedroom. What went wrong? A diuretic works by making your kidneys produce more urine. That is its entire purpose. If you take it in the evening or just before bed, you are essentially scheduling a series of bathroom trips for the hours when your balance is worst, your vision is bleary, the house is dark, and your reflexes are slowest. Now layer on top of that the normal overnight blood pressure dip. Add mild dehydration from increased urination. Add the disrupted sleep, making him groggier. Add arthritic joints that take a moment to cooperate and a hallway he is navigating in the dark. Frank's healthy bedtime routine had quietly become a setup for disaster. And there is a detail here that most people overlook entirely. Repeated nighttime waking does not just affect balance. It disrupts sleep quality, which increases daytime fatigue, which worsens concentration, which increases fall risk the following day as well. Chronic broken sleep can also worsen dehydration over time, which then makes episodes of low blood pressure even more pronounced. It is a cycle that compounds itself. But the risk of nighttime blood pressure medication is not limited to people taking diuretics. That is the part I really want you to absorb. Let me tell you about Louise. Louise was 79. She was not taking a water pill at all. She was on a long-acting blood pressure medication and a second tablet for heart protection following a cardiac event some years earlier. Her blood pressure readings looked wonderful, numbers that would make any doctor smile. 118 over 68, 116 over 66, 112 over 62. Louise was proud of those numbers. Her family was reassured by them. Then she started noticing something. Not during the day, not while seated or walking around the house, only at night or first thing in the morning when she rose from bed. She would stand up and feel a wave of emptiness flood through her head, a hollow, collapsing sensation, as though something inside her body had briefly switched off. She described it to me as the sinking feeling. That sinking feeling has a medical name, orthostatic hypotension, or postural hypotension. In plain English, it means blood pressure drops when you move from lying or sitting to standing, and it is far more common and far more dangerous in older adults than most people realize. Here is what happens in the body during those few seconds. When you stand up, blood naturally pools downward into the legs and abdomen due to gravity. In a younger, healthy person, sensors in the blood vessels detect that shift almost instantly and instruct the heart and vascular system to compensate. The pressure corrects within seconds and nothing unpleasant is felt. But as we age, that response slows. It becomes less precise. Add medication that is peaking overnight. Add the slight dehydration that comes from a night without fluids. Add the warmth of the bed, making blood vessels slightly more relaxed. Add rising quickly from sleep, and that brief pressure drop can become dramatic. That is, the sinking feeling. And in older adults, it does not just mean discomfort. It can mean blacking out. It can mean a fall. And a fall in someone over 70 can mean a fractured hip, a head injury, and in some cases, the beginning of a significant and permanent decline in independence. Now, I want to pause here and say something important. I am not telling you to stop taking your blood pressure medication. I am not telling you to move your medication on your own. I am not telling you that bedtime is always wrong. For some people, an evening or bedtime dose is exactly the right clinical decision. And if your doctor has specifically reviewed your situation and prescribed accordingly, that decision may well be correct for you. What I am telling you is this. For many seniors, bedtime is the most dangerous time to take blood pressure medication, when that timing has never been individually reviewed. When the person has symptoms of low blood pressure, when they get up repeatedly overnight, when the medication itself creates overnight problems. In those situations, a routine that looks disciplined and responsible on the outside can be quietly hazardous on the inside. Let me show you the contrast through a man named Walter. Walter was 68. His mornings were consistently the most difficult part of his day. He would wake up to blood pressure readings that were significantly elevated before he had even had breakfast, even though the rest of the day looked acceptable. Walter was not dizzy. He was not making repeated nighttime bathroom trips. He had not had any falls. He had no symptoms of low blood pressure. After thorough review and extended monitoring, one of his medications was timed later in the day, and it helped significantly. Why? Because the decision was based entirely on his specific pattern, his physiology, his risks, his symptoms, his response to treatment. That is what safe, intelligent medicine looks like, not copied from a neighbor, not borrowed from a health headline, personalized to the individual. And that is precisely why generic internet advice about medication timing can become so dangerous. Blood pressure medication does not simply lower a number on a monitor. It interacts with your kidneys, your sleep, your circulation, your bathroom habits, your balance, your vision, and all of your other medications simultaneously. And seniors often have multiple vulnerabilities present at the same time. One person has glaucoma, another has nerve damage from diabetes, another has significant swelling and takes a diuretic, another already experiences lightheadedness from a different medication, another lives entirely alone and would remain on the floor for hours if they fell. All of these people may carry the same diagnosis of high blood pressure, but their risk profiles are completely different, and their medication timing should reflect that. I want you to hold on to one sentence. It is the most important thing I will say today. The most dangerous time to take blood pressure medication is the time that drives your pressure too low during your most vulnerable hours. For many older adults, those vulnerable hours are overnight, when the body is already naturally dipping, when you may suddenly need to stand up quickly in the dark, when your balance reflexes are at their slowest, when the house is quiet and no one is nearby to help. That is not because night is inherently harmful. It is because the particular combination of sleep, posture changes, nighttime bathroom trips, medication effect, and the physiological changes of aging can come together in ways that create serious risk. Let me tell you about Gloria, because her story illustrates something I see happen again and again. Gloria was 74. She had recently become very motivated about her health after a high blood pressure scare. She was walking more, eating better, checking her readings regularly, doing everything right. Then she watched a short video online claiming that taking all blood pressure medication at bedtime provided superior heart protection. She found it convincing. So, without asking anyone, she switched her entire routine. Within 2 weeks, her mornings were miserable. She felt thick-headed, weak, and sluggish when she woke. She thought she was just aging. She blamed poor sleep. She blamed stress. It genuinely never occurred to her that the new timing was the cause. When she finally saw her doctor, they checked her blood pressure while she was seated and then again after she stood. The difference was striking. The medication, now peaking overnight, was driving her morning pressure lower than her body could tolerate safely. The medication had not become dangerous by itself. The timing had made it so. And there is one more misunderstanding I need to address because it traps so many well-meaning people. The idea that lower blood pressure is always better. It is not. Lower is not automatically safer. Lower is not automatically healthier. In older adults especially, blood pressure that is driven too low reduces blood flow to the brain. It causes fatigue. It worsens confusion. It contributes to falls. And because so many seniors have been taught to fear high numbers, they sometimes look at very low readings and feel pleased, without asking the question that actually matters. Low for whom and at what cost? A reading of 108/62 might be entirely appropriate for one person and genuinely dangerous for another if it comes with dizziness, weakness, and blacking out on the way to the bathroom. Pretty numbers achieved at the expense of real-world safety are not a success. They are a warning. Now I want to talk about something that receives far too little attention because it contributed to one of the most preventable and heartbreaking situations I have encountered: the missed dose trap. Harold was 71. He occasionally forgot his morning tablet. On those days, he would take it at bedtime instead, reasoning that he did not want to miss a dose entirely. Then the following morning, not wanting to fall behind, he would take his next dose as usual. He was not trying to harm himself, he was trying to be responsible. But what he had accidentally created was a compressed dosing interval. 2 doses taken too close together. And that is one of the fastest ways to produce unexplained dizziness, an abnormally low blood pressure reading, or fainting, particularly in older adults who may be smaller in frame, mildly dehydrated, or already taking more than one blood pressure medication. The dangerous time is not only bedtime taken by routine, it is bedtime taken as an improvised catch-up after a forgotten daytime dose. If this sounds familiar, please hear this clearly. Never create your own catch-up plan for blood pressure medication unless your prescribing doctor or pharmacist has given you specific instructions for exactly that situation. Different blood pressure medications have different half-lives, meaning different durations of action in the body. Some formulations release slowly over many hours. Some release quickly. Some missed doses should be taken as soon as you remember. Some should simply be skipped. Some absolutely must not be taken twice in a short window. And seniors managing multiple medications, sometimes prescribed by different specialists, sometimes with instructions that changed after a hospital stay, are at particular risk of these compounding errors. One small, well-intentioned adjustment to the schedule can quietly turn a safe routine into a hazardous one. There is one more factor that makes bedtime more dangerous than people realize, and it is something that creeps up on older adults so gradually they often do not notice it until something goes wrong. Dehydration. Not dramatic dehydration, not the kind you associate with a heat wave or illness. I am talking about the mild, everyday dehydration that accumulates quietly in older adults. A little less thirst than before, a slightly smaller water intake, a warm house, a day with a stomach upset, a water pill adding to the fluid loss, a poor appetite reducing fluid from food. Your circulating blood volume drops, meaning less fluid is moving through your vessels. Then you take your blood pressure medication before bed. You lie down. You wake at 3 in the morning. You stand up quickly. And what would have been a manageable pressure drop in a well-hydrated body becomes a dramatic one. Other medications can amplify this effect significantly. Alcohol relaxes blood vessels and blunts the body's corrective reflexes. Sleeping tablets reduce alertness and coordination. Certain pain medications affect blood pressure regulation. Some prostate medications and antidepressants lower blood pressure as a side effect. When these are combined with a bedtime blood pressure tablet in a mildly dehydrated older adult, the margin of safety becomes very thin. This is why senior medicine is less like following a recipe and more like conducting an orchestra. Each instrument may sound fine in isolation. It is when they all play together at the wrong moment in a particular combination that the result can be harmful. Now we are reaching the heart of what I want to leave with you today. The most dangerous time to take blood pressure medication for many seniors is right before bed. Specifically, if you are taking a diuretic, a water pill. If you regularly wake during the night to urinate. If you have ever felt dizzy or unsteady when standing up. If you have had a fall in recent years. If your blood pressure already tends to run low overnight. Or if your current schedule was never specifically reviewed and adjusted for your individual situation by a clinician. That is the warning I need you to carry with you. And equally, I need you to hear the second half of that message. For some patients, bedtime is the medically appropriate choice. The danger is not bedtime itself. The danger is the untested assumption that it works for everyone. The danger is the self-directed switch based on something you read or heard. The danger is ignoring symptoms because the timing sounds medically impressive. So, how do you know if your timing may be wrong for you? The body usually tries to tell you, but it does it quietly, especially at first. You feel unsteady when you rise from bed. You feel foggy, strangely weak, or almost drugged in the morning. You have had near falls in the bathroom. You find yourself reaching for the wall before taking your first few steps. Your vision dims briefly when you stand. You feel noticeably better if you sit back down for a moment. Your lowest blood pressure readings of the day coincide with your worst feeling moments. These are not trivial annoyances. These are signals. They may mean that your pressure is dipping too low at the most vulnerable time of day. I want you to hear about Anita, because her story is the one I would want every adult child to hear and share with their parents. Anita was 81, still living alone, fiercely proud of her independence. She would never ask for help unless she absolutely had no choice. Her children had begun noticing over recent months that she sounded a little different in morning phone calls. Slower, slightly less sharp than usual, a little quieter. Anita said she was perfectly fine. She put it down to disrupted sleep. Then one morning, she missed a step coming down from her bedroom and twisted her ankle badly. Everyone assumed it was the stairs. But when her doctor reviewed her full picture, her medication schedule, her overnight patterns, her standing blood pressure measured both sitting and standing, the story became clear. Bedtime medication, regular nighttime bathroom trips, morning dizziness she had never mentioned because she did not want to worry anyone, and a standing blood pressure first thing in the morning that was far lower than it should have been. The stairs were not the cause. Timing was. And that brings me to something that adds another layer of sadness to these situations. Many seniors do not report their dizziness. They do not mention grabbing furniture to steady themselves. They do not bring up the moments where the floor seemed to shift. They assume it is just aging. They do not want to seem fragile or dependent. But blood pressure care is not just about achieving good numbers on a monitor. It is about how you function in real life. Can you rise safely from bed? Can you walk to the bathroom without fear? Can you think clearly when you wake up? Can you navigate your own home with confidence? If the answer to those questions is no, then your current regimen may be producing impressive figures on paper while quietly reducing your quality of life and your physical safety. Now let me talk practically about the medications themselves, because this is where clarity becomes genuinely useful. If you are on a diuretic, a water pill, bedtime is very often not the right time to take it, unless there is a specific clinical reason your doctor has given you. Taking it in the morning or early afternoon usually allows the peak urination effect to pass well before you go to sleep, reducing nighttime waking significantly. If you are taking a long-acting blood pressure medication that does not cause dizziness for you, and your doctor has recommended later dosing to address a particular pattern in your readings, an evening dose may well be appropriate. The key phrase is your doctor recommended it based on your pattern. If you are on more than one blood pressure medication, splitting the timing between morning and evening is sometimes beneficial, but only when that decision has been made as part of a proper review, not as something you have arranged yourself. If you experience side effects after taking any blood pressure tablet, dizziness, weakness, nausea, unusual tiredness, that symptom is clinically relevant. It is information. It needs to go to your doctor. The right medication schedule is one you can maintain safely, remember consistently, and tolerate without placing yourself in danger, not the one that sounds most medically impressive. Some people need more detailed evaluation than a routine office visit can provide. Consider Robert, who was 73. His blood pressure readings at clinic appointments looked acceptable, but he was experiencing morning headaches and episodes of feeling woozy at night. The pattern made no sense until he underwent ambulatory monitoring, a small device worn for 24 hours that records blood pressure continuously throughout the day and night. That revealed the real picture. His pressure was dipping excessively overnight and then surging sharply in the hours before waking. If his doctor had simply added more evening medication without that information, he could have become significantly more unstable. Instead, the regimen was carefully adjusted, not dramatically, just precisely, and his symptoms resolved. That is why guessing is so dangerous. And that is why I want to say this plainly. You cannot determine the safest medication timing for yourself from the internet alone. You can learn principles here. You can learn warning signs. You can learn the right questions to ask. But your safest schedule can only be determined with knowledge of your specific blood pressure pattern over a full day, your kidney function, your fall history, your vision, your sleep quality, your other medications, and the overall state of your cardiovascular system. Those things differ enormously from person to person, and in older adults, those differences carry greater consequences because the margin for error is smaller. A younger person who feels briefly dizzy may simply sit down. A senior may fracture a hip. So let me give you a practical 5-step approach you can begin using right now. Write down every blood pressure or heart-related medication you take, including the exact time you take each one. Not roughly, exactly. For 1 to 2 weeks, keep a simple note of any dizziness, blurred vision, unusual weakness, nighttime bathroom trips, near falls, or moments of unsteadiness, and write down what time each one occurs. Check your blood pressure when you feel well and when you feel symptoms. If your doctor has shown you how, check it while seated, and then again after standing for 1 to 2 minutes. The difference between those two readings can be very revealing. If you are taking a diuretic and you are currently taking it in the evening or at bedtime, and you are waking multiple times a night, raise that with your doctor or pharmacist as soon as possible. And then bring the whole picture, the medication list, the symptom notes, the blood pressure log, to your doctor or pharmacist and ask this specific question. Is the time I am currently taking my blood pressure medication increasing my risk of overnight low blood pressure, dizziness, or falls? That question puts the focus exactly where it needs to be, on your risk, your body, your real-world safety, not on what sounds medically fashionable. If you live alone, this conversation becomes even more urgent. A nighttime blood pressure event in a home with no one else present is a very different situation from the same event in a home where someone is nearby. A moment of faintness in an empty house can mean lying on the floor for hours. A bathroom trip in the dark can become an ambulance call. A medication schedule that appears tidy and responsible on paper can become genuinely hazardous in a real home with real stairs, real rugs, real darkness, and real aging joints. That is not a reason to feel frightened, it is a reason to act, and to protect the independence you have worked so hard to maintain. I also want to speak briefly to anyone watching who has a loved one with a history of eye disease, especially glaucoma, or a history of unexplained falls, or conditions like Parkinson's disease, diabetic nerve damage, or dementia. In those situations, blood pressure regulation is already more fragile. The body's ability to rapidly correct a pressure drop when standing is already compromised. Medication timing in these cases is not a minor administrative detail. It is a significant clinical decision that deserves careful, individualized attention. Let me close with the story I want most to stay with you. Her name is Margaret, 78 years old, active, thoughtful, and becoming increasingly anxious because she kept feeling unsteady in the mornings and could not understand why. She had assumed it was aging. Her daughter assumed it was tiredness. A well-meaning neighbor told her she should be grateful her blood pressure was so nice and low. But Margaret paid close attention. She started writing things down. She noticed the dizziness was worst between 5 and 8 in the morning. She noticed it was reliably worse after getting up in the night. She brought that log to her doctor. Her doctor reviewed the full picture. One medication was moved earlier in the day. Another stayed where it was. The timing of the diuretic was shifted to early afternoon. Within days, the morning heaviness lifted, the dizziness eased, the fear that had crept into her daily routine disappeared. Same woman, same medications, different timing, safer life. That is what this conversation is for. Not to create fear, not to make you doubt your doctor, but to give you the awareness and the language to ask better questions and advocate for your own safety. Let me say the core warning one final time. The most dangerous time to take blood pressure medication for many seniors is right before bed without individualized clinical review, particularly if you take a diuretic, particularly if you wake during the night, particularly if you have ever felt dizzy on standing, particularly if you have had falls, particularly if there are signs that your blood pressure may be dropping too low in the overnight hours. The danger is not your medication. The danger is not your diagnosis. The danger is the wrong timing for the wrong body at the wrong hour of the night. And the good news, and I want you to hear this clearly, is that timing can almost always be adjusted once the pattern is identified. This is a fixable problem, but only once it is seen. Please do not stop your medication, skip doses, double up, or rearrange your schedule based on this video alone. Use this as the reason to observe carefully, document what you notice, and walk into your next appointment with better questions. If you have been experiencing dizziness, weakness, near falls, or unsteadiness after taking your blood pressure medication, please tell your doctor promptly. Do not wait until something worse happens. Do not dismiss it as just aging. These are clinical signals that deserve a clinical response. If you found something in this video that made you think, please share it. Share it with someone over 60 who takes blood pressure medication and has never once thought about whether the timing is right for them. Share it with a daughter or son who wants to understand why their parent seems off in the mornings. Share it with a friend who takes their tablet dutifully every night at bedtime without ever questioning whether that is the safest choice for their body. That kind of sharing genuinely saves lives. And if you are not yet part of our community here, I would love for you to subscribe. Every week we bring you clear, practical, research-supported health guidance designed specifically for people in their 50s, 60s, 70s, and beyond. Because you deserve information that takes your real-life situation seriously. Leave me a comment below. Tell me whether this gave you something new to think about. Tell me if you are going to raise the question of timing at your next appointment. Your comment might be the thing that encourages someone else to do the same. Your medication should be working for you, not against you. Your blood pressure routine should be protecting your heart, your brain, and your ability to move safely through your own home, in the daytime and in the dark. I am Dr. Benita Fieldhouse. Take good care of yourself, and I will see you in the next one.